Good morning, Professor Verstovsek. Thank you very much for attending me as usual. Today, we would like to talk about the interferon. And it's a big item between the patient community. And I hope you can explain us a few points. I have three questions to you. The first one is, could you explain the difference between interferon alpha and the therapeutic interferon, please?
Having opportunity to work in the field for a long period of time, I'm very closely related to development of interferons. Interferon is a biological product. We have interferon in our body. It goes up when we have inflammation or infection. It's kind of immune booster. And there are different types of interferon, alpha, beta, gamma, and so on. They have their roles in the immune system to different extent and other actions in the body. Now, as an injection under the skin, interferon has been around for 50 years, and it used to be given as injection under the skin once a day, or because the tolerance was poor, maybe 3 times a week. The tolerance is poor because when you give injection, it causes flu-type symptoms, and over a longer period of time, it can also cause some autoimmune problems or depression. The new ones, the new interferons that now are around for quite some time are so-called long-acting ones. They have pegylated form. That's the chemical structure. That's why we call them pegylated interferons. That is attached to interferon. That the interferon molecule is not really changed. It's just attaching something to it, make it slow release. So you have on the market actually for hepatitis, couple of long-acting interferons for last more than 10 years, actually 20 years, that are being used off-label in patients with polycythemia vera and ET. The therapeutic interferon is the latest addition to this long-acting interferon. The key here is that the pegylated part is different, and it allows the administration of this interferon preparation every 2 weeks. So even less often. When you have less often administration, you have a lower, possibly lower problem with the side effects, flu-type symptoms. So no low-grade fevers, night sweating, no muscle aches and pains that are common with frequent injections. And that tolerance then translates to better results. And as you know, we have in Europe at least a chance to use it in commercial setting for polycythemia vera patients. So it's chemically different pegylated part that allows it to be given every 2 weeks. And with that, the tolerance and the activity, everything is improving.
Okay, thank you very much. What are the actual test results of Bezremi? Could this be the cure for PV?
Well, to start talking about the cure is it's very high bar. What we know so far in the studies that led to its approval in Europe for polycythemia vera, that in polycythemia vera patients, and that was studied in the beginning of the journey of patients with polycythemia vera, so early stage patients, not very advanced patients, which is proper use of interferon in general. It can, in about 3/4 of the patients, normalize the blood cell count, which is the main goal of therapy. Remember, the normalization of the blood cell count, particularly control of the red blood cell count, which is usually measured by hematocrit, maintaining hematocrit below 45%, is the goal because that is proven to decrease the risk of thrombosis, and that decreases the risk of dying. In addition, it has been known for all these 50 years of use of interferon that if you can deliver interferon, it can modify perhaps bone marrow, improve it. It can possibly decrease or even eliminate detectable cells with a malignant mutation. We are talking about the JAK2 V617F mutation that drives the polycythemia vera as a disease. We can measure it in a sample from the patients. This is called JAK2 allele burden. And you can tell, this is not very often done, but you can tell how many cells are affected in that sample from that particular patient by that mutation, which would be a burden of the disease. We know that interferon has a potential to decrease it and possibly even eliminate cells with the mutation. And for therapeutic interferon, after 5 years of follow-up, we learned that last year, about 14% of the cells eliminate detectable JAK2 positive cells. We call this complete molecular response. Now, we don't know really what this means. The idea is, and hope is, that this, if it's maintained like that, would lead to less of a risk of progression to myelofibrosis or acute myeloid leukemia, or you can contemplate even stopping the therapy with interferon because no evidence of the disease. But we also learn on the other side that disease may have some other mutations present. And so it's work in progress. It's not to say that with elimination of the JAK2 mutation, you have a cure. We are not there yet. We are aiming to that goal, and we are going in the right direction, but it's not time yet to start talking about the cure. We are talking about a complete molecular response in some patients after a long period of time, and hopefully this will translate in further benefits, clinical benefits that are still exploratory in nature. Still, the goal is to control the blood cell count, decrease the risk of thrombosis, decrease the risk of dying from the blood clot. That's the primary goal. The rest is still investigational, exploratory in nature, if you like.
Okay, thank you. Besremi has been registered for PV, but as far as I know, it's also applicable for ET and MF.
So you are correct. 2019, it was approved in Europe for polycythemia vera patients, and that would be specifically for polycythemia vera patients without splenomegaly. Remember, it was studied in early stage patients that didn't have a big spleen, so activity on the spleen is unknown. And then the results, about 75% patients achieving complete hematological response, is why the drug was approved, right? So control of the blood cell count. So now we are expecting the same medication, the Therapeutic Interferon, commercially known as Besremi, to be approved in United States. Application is under review. Possibly by the end of this year, we will have it approved for PV patients in United States. And then, I don't know, around the globe in other countries, but hopefully one country at a time. And so this is active medication. It builds on the history of interferons being active, appears to be safer, appears to be able to be delivered less frequently, and then for much, much longer than standard interferons in the past. So all positives is here for us to benefit our patients, and maybe, as we just discussed, look at this complete molecular response as the next step in evolution of what we aim for with therapies in PV. The similar situation is in ET, right? The patients with essential thrombocythemia. It's similar, and there is a global study underway comparing Therapeutic Interferon to anagrelide. Anagrelide is medication that is approved for patients with ET to control the platelets. This study is global study. It's not blinded because the Therapeutic Interferon is injection and anagrelide is a pill, but it is specifically for patients that were previously treated with hydroxyurea. Hydroxyurea is a standard frontline therapy for patients with ET to control the blood cell count. So it's a second-line therapy comparing two modalities, approved therapy anagrelide to Therapeutic Interferon. It's a global study, and it is specifically for patients that have high platelets and the high white cells. Remember, 10 to 20% of ET patients do have high white cells too. It's not just the platelets. So it is underway. We don't know exactly where we stand with accrual and when this is going to finish, but it's very exciting to have a potential of Therapeutic Interferon becoming new therapy for ET as well in 2 or 3 years. For myelofibrosis, I'm not aware of studies with Therapeutic Interferon yet, but I would envision in the future that there would be a role for this therapy in earlier stages of myelofibrosis, like prefibrotic myelofibrosis, patients that come with no much fibers, no big spleen, suffer, for example, with a high blood count, as early stage myelofibrosis usually present with high platelets or high white cell count. In that setting, it might be active, but I'm not really aware of any study for its approval in myelofibrosis.
But it would be logical, no? But well, as far as you can talk about logical in science.
Yeah, I mean, it is logical. And I mean, there is a good reason why I use it. This is a spectrum of conditions. We just call it different way, but patients suffer from similar conditions, right? The high blood cell count, they are driven, the diseases are driven by the JAK-STAT pathway hyperactivity. So that's all in common. And the goal is to control the blood cell count as the first order of priority to decrease the thrombotic risk. It's all subject possibly to Therapeutic Interferon in the future.
Yeah, because I have patient friends here in this country, and where a little burden, which was very, very high, came down with a product to below 1%. And it stays there. So
that's excellent. So now the question is, what does this mean? Does this mean really that we should be talking about stopping the therapy for some time, and maybe you can have a drug holiday for a few years and follow just the allele burden. What's the meaning of that? Does this mean less of a progression? I would assume so, but we don't have the definitive answers to be able to advise patients to aim for molecular response. It's not even being tested regularly in everyday practice. And to say that this is really something that we can say meaningful at the moment. It's exploratory. We have to have time for knowledge to accumulate. What does this molecular response means?
Yeah, no, but patients who I talk to you about, they are now since about 6 months on a test without taking anything. So at the moment it goes okay, but 6 months is obviously nothing. So we will have to wait a little bit. But I think this is excellent news, and I think all our patients can be very optimistic for that. Yeah,
absolutely. Optimism is necessary, but really this is very good news for further development of these therapies and for us to think beyond just blood cell count. Let's aim for the cure if we're not there yet.
Absolutely. Professor Verstovsek, I thank you very much for this time you have given to me, and our patients will be very happy to hear about your news. Yeah, I wish you a beautiful day and a very good week.
My pleasure. Thank you so much.